Yes, yes.
So, topic is adenovirus nephropathy. Adenovirus is a non-enveloped double-stranded DNA virus with icosahedral capsid and characteristic fiber protein, as shown in the picture. There are more than 60 serotypes, which are classified into 7 species A to G. And this virus is studied as vector for gene therapy and vaccines like Ebola and SARS-CoV-2. 80% of the general population is infected by at least one serotype by the age of 6, mostly as respiratory infection. It's more common in children than in adults and occurs throughout the year. It is non-seasonal. In adults, the risk is greatest when people are living in close quarters or when they are immunocompromised. Once they get an acute infection in an immunocompetent individual, adenovirus will be shed in the stool for weeks, and in an immunocompromised patient, it can be up to months. Transmission is by aerosol droplets, fecal-oral route, direct conjunctival inoculation, contact with the contaminated fomites, tissue, blood, cervical secretions, and solid organs in transplant. Incubation period that depends upon the serotype and the mechanism of transmission. It can range from 2 days to 2 weeks. In an immunocompetent individual, usually it is self-limited, requiring only supportive measures. Immunocompromised individuals, it can be disseminated with disease being fatal. This is the tropism of human adenovirus with various organ system involvement. In central nervous system, it results in meningoencephalitis, cardiovascular system, myocarditis, and dilated cardiomyopathy. Gastrointestinal tract, it can result in gastroenteritis, diarrhea, intussusception, appendicitis, mesenteric lymphadenitis, and hepatitis. Urinary tract as hemorrhagic cystitis and nephritis. Eyes, it can cause follicular conjunctivitis, pharyngoconjunctival fever, epidemic keratoconjunctivitis, and hemorrhagic conjunctivitis. Respiratory tract involvement, upper respiratory and lower respiratory as acute bronchiolitis, bronchiolitis obliterans, and pneumonia. Also, it can cause arthritis, thyroiditis, skin exanthems, and hemophagocytic lymphohistiocytosis. So, coming to the kidney involvement, usually by serotype C and less commonly by serotype B. This virus infects the renal tubular epithelial cells, especially distal tubular epithelial cells, resulting in direct cytopathic effects and inflammation. Usually in children, it manifests as hemorrhagic cystitis. Child will be presenting with fever with hematuria, and rarely in an immunocompetent individual, adenoviral interstitial nephritis. Adenovirus in transplant recipients is usually rare. It occurs in the first post-transplant period, is the more risky period. In kidney transplant recipients, in the first year post-transplant, asymptomatic viremia is noted in 6.5%. Out of this, only 10% goes into invasive disease. And this infection, acute infection in a transplant recipient can be donor-derived or reactivation of the latent infection or a primary infection. If it is primary infection, it can be late onset. This donor-derived and reactivation of latent infection manifests in the early period. Reactivation can occur because once you get an adenovirus infection, this can have a carrier state in the lymphoepithelial tissues, renal parenchyma, tonsils, adenoids, and gastrointestinal tract. And this will get reactivated when your immune status goes down. Clinical manifestation in transplant recipients are hemorrhagic cystitis, nephritis, pneumonia, enterocolitis, orchitis, lymphopenia, and disseminated disease. Disseminated disease in a clinically significant patient with viremia and 2 or more organ involvement is considered disseminated disease. Clinical manifestations, already mentioned, hemorrhagic cystitis. This is usually the first sign of infection in a transplant patient with person will be presenting with hematuria and dysuria. Tubulointerstitial nephritis, it will go to acute kidney injury with the inflammation of the tubules and interstitium. And even the ureteral obstructions can result in obstructive uropathy. That can also worsen the kidney function, and systemic infection, systemic illness, which progresses to widespread infection as disseminated infection. In the early days, it will be mistaken for common post-transplant symptoms like fever, malaise, and fatigue in 1 to 3 days. Then when it advances by 4 to 7 days, slowly the creatinine will be creeping up, and with decrease in urine output. Established infection occurs by week 2. With this time, patient will be having hematuria, dysuria, and flank pain. By week 3, severe disease with severe acute kidney injury, systemic involvement, disseminated disease, and requiring hospitalization and even dialysis. Risk factors are first year post-transplant is the highest risk period. because of the high dose immunosuppression and enhanced vulnerable period and compromised immunity that will reduce the viral clearance. Pathophysiology, the virus enters into the distal tubular epithelial cells through the receptor binding and undergoes viral replication and inflammatory response by cytokine release and tissue damage, cell lysis, necrosis, and disrupting the kidney function. So the diagnostic approach, a high degree of clinical suspicion is needed, identifying at-risk patients with symptoms suggestive of viral nephropathy. We should include adenovirus also. Non-invasive testing, it includes PCR testing of blood and urine for adenovirus DNA. Gold standard for diagnosis is by allograft biopsy. That also helps in assessing the tissue damage. And you can have immunohistochemistry and electron microscopy to confirm the viral presence. Histopathological features as necrotizing tubulointerstitial nephritis, extensive distal tubular necrosis with the intense inflammatory infiltrates will be the characteristic feature, and more than 85% will be having a granulomatous inflammation. That is characteristic of adenovirus. And compared to other viral nephropathies, this will have minimal scarring and less fibrosis. And characteristic viral inclusions, early infection, there will be eosinophilic small nuclear inclusions, which will become enlarged basophilic intranuclear inclusions in the later stage of infection. When the inclusions merge with the nuclear membrane, it will have a smudgy appearance, and this is also called Cowdery A-type inclusions. This is a H&E stain pathological picture showing the inclusions. You can see the enlarged smudgy nuclei with intranuclear inclusions in the distal tubular epithelial cells. And this is the multifocal tubulocentric necrotizing granuloma with interstitial inflammatory infiltrate in H&E stain. In immunohistochemistry, by using specific antibodies, we can detect viral antigens in tissue sections, which will give positive immunoperoxidase staining that will show the nuclear and cytoplasmic patterns that will confirm the viral presence. This is the immunohistochemical stain, which shows the nuclear and cytoplasmic staining of adenovirus infected tubular epithelial cells. Electron microscopy will visualize the actual viral particles within the cells. The viral particles of size 75 nanometer in diameter and the characteristic icosahedral shape we can see that will be definite for adenovirus. This is the electron microscopy, which is showing non-enveloped hexagonal viral particles aggregated in crystalline arrays within the nucleus of infected cells. So this is the pathology appearance, and there are some features which distinguishes it from common viral nephropathies, that is BK virus nephropathy. Adenovirus nephropathy usually clinically comes with gross hematuria, but BK nephropathy gross hematuria is rare, comes with microhematuria. And prominent granulomatous inflammation is characteristic of adenovirus, and minimal granulomatous feature for BK virus nephropathy. Minimal interstitial scarring, but scarring will be extensive tubulointerstitial scarring for BK virus. And rapid viral clearance occurs from the plasma in adenovirus, and persistent viremia will be noted in BK virus. And the nuclear inclusions are smudgy basophilic in adenovirus and ground glass nuclear inclusions in BK virus. So this is the slide which compares the features of adeno, BK, and CMV. The prevalence of viremia is, I already mentioned that, around 6.5% for adenovirus, and polyoma is more prevalent, viremia 12%, and it is highly variable for CMV. Graft infection more with polyoma than adenovirus, and it is usually rare with the CMV. Clinical features, systemic symptoms are rare with polyoma, but commonly seen with adeno and cytomegalo. Organ involvement is confined to kidney, and other organ involvement with adenovirus and CMV. Prognosis, usually adenovirus, it can be life-threatening, but usually of acute interstitial nephritis pictures, and scarring will be less, and it can be reversible. But polyoma, it goes into graft failure and usually a chronic picture. And graft involvement and chronic graft failure is not that recognized cause in the CMV. Viral inclusions, nuclear and cytoplasmic inclusions are there. Nuclear inclusions can be seen in all the viruses. Ground glass homogeneous, characteristic more for adenovirus, and the halo is more for cytomegalovirus, that owl-eye appearance we see in CMV, and granular clumped appearance for polyoma virus. Cytoplasmic inclusions are rare with adeno and polyoma, but can be seen with cytomegalovirus. Site of replication usually tubular and Bowman's capsule to epithelial cells in all the viruses. And the histopathologic pictures like acute tubular injury, interstitial inflammation, focal parenchymal necrosis, interstitial hemorrhage, granulomatous inflammation, more severe with adenovirus compared to other viruses. Diagnosis, this is about the histopathology. Diagnosis by blood and urine investigations. You can look for the DNA, adenovirus DNA PCR. In the blood, we can quantify the viral DNA in the plasma. Levels more than 10,000 copies per ml is indicative of active disease. And urine, also we can do urine adenovirus DNA PCR because we detect the viral shedding in the urine. It will be positive even before the blood test is positive, and more than 1 lakh copies per ml is considered positive in urine. And this is highly specific for urinary tract involvement. Also in urine cytology, which will show the viral cytopathic effect, that also direct evidence of infection. PCR is highly sensitive and specific, which is helpful if it is taken from sterile sites like blood, CSF, and tissues. And if it is taken from respiratory tract, stool, urine, it may be viral shedding, but needs to be correlated with symptomatic infection. Other diagnostic modalities are viral culture, which shows the characteristic cytopathic effect, except in types 40 and 41. Cytopathic effect generally occurs within 2 to 7 days with the more common lower serotypes, but it can take up to 28 days in serotype subgroup D. Viral antigen assay by using adenovirus specific enzyme immunoassay or immunofluorescence assay. It is rapid but less sensitive, and the use in immunocompromised host is not that sensitive. Serology, same like CMV, we can use IgM, IgG antibodies. Differential diagnosis, acute rejection is the most common differential diagnosis. Similar clinical presentation can be there. In rejection, there will be tubulitis with lymphocytic infiltration, and there can be vascular inflammation in glomerulus and blood vessels. P40 can be positive, and there won't be viral inclusions and no granuloma in rejection. But both rejection and adenoviral nephropathy can coexist. Drug-induced nephritis, as eosinophilic infiltrates, and there won't be inclusions. BK virus nephropathy, this is more common than adenovirus, and the viral inclusions are ground glass, irregular intranuclear, and greater scarring and less systemic involvement. CMV, more of systemic manifestations, less graft involvement, and distinct owl-eye inclusions and nuclear and cytoplasmic inclusions. This is a differentiation of each viral nephropathy. Treatment strategy is reducing the immunosuppression. This is the first line intervention, and supportive care to maintain the kidney function, antiviral therapy for persistent or severe disease. Immunosuppression management, we should evaluate the patient's current immunosuppression regime and the disease severity, viral load, and the rejection risk all to be balanced, and reduce the antimetabolites first and modify the calcineurin inhibitors and adjust the mTOR inhibitors, and to monitoring the response by tracking viral clearance and kidney function, monitor the viral load weekly, creatinine daily, and watch for rejection signs. Coming to the antivirals used in adenoviral nephropathy, cidofovir is the most common. This is the first line and most commonly used. This is a nucleotide analog that inhibits viral DNA polymerase and leads to chain termination. This is active against all the serotypes of adenovirus. But the problem is nephrotoxicity. It can result in acute kidney injury and Fanconi type syndrome. So it is not that preferred as a first line treatment in kidney transplant. If at all to be used, it requires dose reduction and probenecid co-administration. So the usual dose of cidofovir is the standard treatment dose is 5 mg per kg weekly. It should be modified as 1 mg per kg every other day or 3 times per week instead of the standard dose to reduce the toxicity. And it should be continued until the resolution of symptomatic disease or viremia. Usually the cidofovir excretion is through the renal as mainly as glomerular filtration. It can also be excreted through tubular secretion through organic anion transporters. Here, when we are combining probenecid, it inhibits the organic anion transporter, preventing the tubular uptake of the drug and decreasing the tubular secretion. Thus, it increases the serum concentration and increasing the bioavailability. So, it should be administered 2 grams per orally 3 hours prior cidofovir, and 1 gram per hourly 2 hours and 8 hours post administration of cidofovir. Other antivirals are brincidofovir. This is the lipid conjugate of cidofovir. Better safety profile with reduced nephrotoxicity and high bioavailability is noted. But because it is not a substrate for organic anion transporter 1, it doesn't get accumulated in the proximal tubules to the same extent as the cidofovir. So that is the advantage of brincidofovir, but issue is availability. Ganciclovir and valganciclovir, these have got limited efficacy against adenovirus. This is active only against subgroup C, but we have the advantage that the kidney infection is mainly caused by subgroup C. So it can be used in renal involvement, but benefit is less. Some case reports are there with improvement with the ganciclovir treatment also. It may be used in combined viral infection. Ribavirin, alternative for mild cases, limited evidence but lower toxicity profile. IVIG, because severe adenoviremia is associated with hypogammaglobulinemia, and IVIG will provide passive immunity with supporting the viral clearance. And it works through multiple mechanisms like neutralization, opsonization, immunomodulation. It can be used as a single agent or a combination with antivirals. So the indication of antiviral or IVIG is in progressive disease despite immunosuppression reduction, and successful treatment will show declining viral load and improving kidney function. So the weekly monitoring of viral load is mandatory, and 1 week after starting antiviral adenoviral PCR quantification, 1 log reduction is considered therapeutic response and a favorable clinical course. Complications of adenovirus nephropathy, graft failure, severe infection will result in even graft loss, systemic dissemination with multi-organ involvement. It can be high mortality rate. Secondary infections, bacterial and fungal infections as complications can occur. Prognosis and outcomes. Prognosis depends on early diagnosis and prompt intervention. Graft loss occurs up to 50% in case studies. Reduction of immunosuppression and balancing should be balanced with the risk of rejection, and close monitoring of graft function is needed. Brincidofovir may offer improved outcomes compared to cidofovir due to the reduced nephrotoxicity. Long-term monitoring is essential. Preventive strategies, screening protocols. As such, there is no currently standardized guidelines recommending for adenoviral screening in transplant recipients. But some centers in hematopoietic stem cell transplant, they do weekly surveillance, and they are detecting the rise in viremia and helps in early identification of invasive disease, even though pre-entry treatment is not that easy with the cidofovir, but we can be more vigilant. Education of patient and staff about the symptoms, of adenovirus infection. And infection control measures like strict hygiene and isolation, if needed, should be done. Vaccination, I'm not aware of any adenoviral vaccine available in India. In US and all, in close quarters, they military camps and all, they administer adenoviral vaccines. Immunosuppression optimization is also needed as a preventive strategy. Emerging therapies, novel antivirals and clinical trials like filocyclovir. Adoptive T-cell therapy, this is T-cell immunity is critical for recovery from adenoviremia. So virus-specific T-cells taken from donors, and that will restore the cellular immunity without increasing the rejection risk. Other emerging therapies for RNA interference and CRISPR-based approaches. Conclusion. Adenovirus nephropathy is a challenging complication of immunosuppression, especially in transplant recipients with graft loss. Early recognition is critical. Consider adenovirus nephropathy in any transplant patient with unexplained renal dysfunction. Elevated adenoviral load in blood may suggest systemic infection, but renal biopsy remains crucial for confirming the nephropathy. Cytopathic effect visible through electron microscopy can confirm diagnosis if other tests are inconclusive. Treatment involves reduction of immunosuppression, antiviral therapy, and balancing rejection. Emerging therapies such as adoptive immunotherapy is holding promise. So, further research is needed to optimize treatment strategies and improve outcomes. So with this, I have 3 cases to discuss. First case is a 30-year-old male. He had undergone transplant in September 2022. with the immunosuppression, interleukin-2 receptor antagonist as induction with the triple immunosuppression. He maintained a creatinine 1.3 milligram per deciliter throughout. 7 months after transplant, came with 3 days history of generalized tiredness and loss of appetite, and 1 day history of fever and hematuria. On admission, his creatinine was 4.7 milligram per deciliter, which was 1.3 milligram per deciliter last visit, 1 month back. And suspected as graft pyelonephritis, his CRP was in the range 100 to 150, and procalcitonin being borderline, counts were within normal, and he was started on broad-spectrum antibiotic meropenem. His renal transplant Doppler was normal, cultures were negative. Despite getting meropenem, he was having persistent high-grade fever with hematuria, gross hematuria persisting. Meanwhile, we got CME, PCR, and BKV, and did other workup also, blood for sepsis panel, urine gene expert TB, TB also we did, and aspergillus fungal evaluation also done, all came negative. And the patient was added with the teicoplanin and antifungals also. By day 3, first adenovirus sample was sent because of the persistent fever and hematuria. The blood adenovirus PCR came as highly positive, 1.17 into 10 raised to 6 copies per ml. More than 10,000 copies per ml is considered significant. And urine adenovirus came as 2.75 into 10 raised to 7 copies per ml. That is more than 1 lakh is considered significant. So with this blood and urine adenoviral positive, immunosuppression dose was modified. And on day 4, graft biopsy was done, and he was initiated on HD also, because his graft function was worsening. After sending the graft biopsy, patient was started on valganciclovir and IVIG, which he received on day 5, day 6, day 7. And he checked his IgG level also, which was also low. But despite this, his fever persisted, gross hematuria persisted with worsening renal function. He was dialysis dependent. He started developing orchitis, pancytopenia, loose stool also. So these are other manifestations of disseminated adenoviral infection. And meanwhile, we got the graft biopsy, which came as adenovirus nephropathy. This was the biopsy report. I couldn't get the slides because already it was in 22, 23. So madam told it is all faded. So this was the biopsy description. All the glomeruli were normal in size and cellularity, G0, CG0, and the tubulodestructive necrotizing granuloma noted at multiple foci, smudgy basophilic intranuclear inclusions in tubular epithelium. This was the picture, and which was suggestive of adenovirus nephropathy, but his immunohistochemical stain came negative. Electron microscopy was not done. So after giving IVIG and the valganciclovir, after completing that received day 5, day 6, day 7, we sent the second sample of adenovirus PCR, which showed 6.73 into 10 raised to 6 copies per ml. That is, it is increased. So patient did not respond with IVIG and valganciclovir. So with that, patient was started on cidofovir on day 8 in view of worsening symptoms, viremia, and no response with valganciclovir and IVIG. After taking a consent with family regarding nephrotoxicity, he received 3 doses, weekly 3 doses. Reduced dose was given, only 187 mg, that is around 2.5 ml, which he received on day 8 and day 15 and day 23. After giving first dose on day 8, we sent the second sample of adenovirus, which we repeated on day 14. Day 8, he received the cidofovir. Day 14, we repeated. From 6.73, it has come down to 1.92 into 10 raised to 4, more than 1 log reduction. That means significant virological response was there. And he received the day 15 dose, and after second dose, again after 7 days, we repeated that further improved the virological response was there, and he received the third dose also. So subsequently, his adenovirus PCR in blood and urine came not detected, and we repeated the urine PCR also, that also drastically come down. But the patient was HD dependent. And he continued on HD. 3 months into adenovirus disease onset, in view of persistent graft dysfunction and despite clearance of viral load, we repeated the renal biopsy, which showed marked tubulointerstitial inflammation, ISTA grade 1 in a background of near normal glomeruli and hypertensive vascular changes. And this time also immunohistochemical stain for adenovirus came negative. And patient was HD dependent. Almost 1 year later of adenoviral disease onset, he presented in May 2023. He came in March 2024. Presented with graft pain and hematuria. Landed up in graft nephrectomy, and graft kidney biopsy showed tubulointerstitial nephritis with hemorrhage and necrosis. So this is the first case. Moving to the second case, another patient, 52-year-old male. He also received interleukin-2 receptor antagonist as induction and triple immunosuppression. 1.5 years later, presented with fever, and his urine showed microhematuria and pyuria, but the cultures all were negative, and his creatinine increased from 1.1, which he was maintaining, to 1.3 to 1.4, and all the cultures were negative, and fever was persisting. And microhematuria, repeated urine analysis also showed microhematuria and pyuria. With that, BKV and CMV done, which came negative. We sent adenovirus also, which showed 80,000 copies per ml in blood. Significant. So we reduced the immunosuppression, and despite reducing the immunosuppression, the repeat adenoviremia level was increasing, and the urine also showed this much copies. So he, in view of the persistent fever and increasing viremia with this other patient, in thinking about the other patient, we started him directly with the cidofovir without going into valganciclovir and IVIG. He received 1 dose of cidofovir in view of the persistent fever and increasing viremia, but only 150 mg he received. And 7 days after administration of first dose of cidofovir, we repeated the adenoviremia, which reduced to 480 copies per ml. Now he is stable with creatinine 1.1 on follow-up. Third case, this is a non-transplant patient. This is actually a 15-year-old male. He came with fever, throat pain and gross hematuria. His urine analysis showed protein of 4+ with gross hematuria, and all in view of fever, all the cultures, everything came negative. And his creatinine also increased from 1.2 to 1.7 with urine PC ratio of 2.4 grams. And repeat urine analysis showed protein 2+ and persistent hematuria. So with this, from pediatrics, they did the adenoviral throat swab, which came in view of this throat pain. The adenovirus throat swab for adenovirus copies came this much copies. And so to check for the renal involvement, I did a urine adenovirus level, which also came more than 1 lakh copies per ml. So, but patient was conservatively managed. He showed his creatinine recovered to 1.1 and hematuria resolved, and so no biopsy was done, and he got discharged. On OP follow-up, he had persistent microhematuria despite decrease in proteinuria. So this time, again, I repeated on OPD basis, I repeated urine adenovirus, which came negative. In view of persistent microhematuria without proteinuria, after 2 months, I did renal biopsy, which showed IgA nephropathy. Thank you.